Hi, this is Dr. Jiha Lee, a rheumatologist from Michigan at ACR Convergence in Washington, D.C. I'm here with Dr. Elam from Augusta University to talk about her abstract number 1746, looking at incidence of osteoporotic fracture in RA population and its relationship to disease activity. As we all know, patients with rheumatoid arthritis are at an increased risk of osteoporosis, and it affects their mobility and function, especially in older adults. And it's an important comorbidity that we need to address. And so, Dr. Elam, what are the traditional risk factors that we consider about, and what tools and approaches do we have, and what made you think that we need to look at disease activity as a measure when we think about this population?
Sure, great questions. So traditional risk factors that we usually think about when we're risk stratifying for fracture are participants' age or people's age. The older you get, the more at risk of fracture you are. There's also race and ethnicity factors as well as your sex, but those are things that aren't modifiable. So the more important things to look at to me are modifiable risk factors. Things like smoking, alcohol use, glucocorticoid use, and then having RA is a risk factor. At this point, we haven't got to the scientific level where we can prevent RA from happening, but there is some data that if you have higher rheumatoid arthritis disease activity, so more active RA, that leads to less bone density or a weaker quality of bone, and then also leads to fracture. So that's what made me interested in wanting to use RA disease activity to maybe help us predict or at least know the incidence rates of fracture by how active the RA disease is.
And we do know that the goal is to go for remission or lose disease activity, because not only does it improve RA-related outcomes, but other comorbidities. And the FRAX score only asks for the yes and no, but you're trying to get at the more granular level. And when you looked at this, what kind of trends did you find?
Right. So what we saw was that for the two different fracture outcomes we looked at in our study were the two fracture outcomes that we use in the FRAX model, which are hip fracture and major osteoporotic fracture, which is a composite of distal forearm, upper arm, spine, or hip fracture. And so we looked at these two outcomes, and we saw that for hip fracture, if you have high disease activity level compared to someone in RA remission, you had higher rates of hip fracture. And then for major osteoporotic fracture, we found that whatever level of disease activity you were above remission, so low, moderate, or high disease activity level compared to RA remission, had greater rates of major osteoporotic fracture.
And how do you bring this into the conversation with the patient when you're trying to talk to them about how to mitigate the risk, whether it be in terms of lifestyle or thinking about how you approach RA treatment?
Yeah, so I think that it's usually not hard to convince an RA patient that they want to be on treatment, usually because a lot of them are having joint pain and symptoms that make them want to get treated. But there are some patients who maybe don't see the benefit of doing a biologic therapy over the medicine that they're already on, and this can add to the data that we have to suggest that really reaching that remission target has benefits even outside of what they're perceiving on the day-to-day in their joints. And then also something that this study didn't look at, but something we're planning to look at in the future, is the issue of glucocorticoids, which we know to be a strong risk factor for fracture, and something that is still used to control RA. And so this just gives us kind of makes the thinking more complex here. Is it that if we control RA, but we're controlling it with glucocorticoids, but those are bad for bone health, maybe we need to make sure we're controlling it with something other than glucocorticoids. And that's sort of the next steps in what I want to look at with this project.
Wonderful. So as you said, we know that RA patients have a higher risk of osteoporosis for 2 to 3-fold. So as Dr. Elam was saying, it's not just about the unmodifiable risk factors, but what we can play a role in is in the modifiable risk factors, particularly when it comes to disease activity, because that is where our skill set lies. So aim for remission and treat the patient, especially when it comes to older adults.